Without much ado, I'd like to introduce Dr. Timur. He's a MD PhD cardiologist and is from the National Medical Research Center, and he's got a huge CV. But just to keep the matter short, that he has done a lot of research and is one of the leading authors in several peer-reviewed publications, including AHJ and PLOS One. And he's also served as assistant professor at Bashkir State Medical University, teaching internal medicine and cardiovascular diagnosis to Russian and international medical students in both Russian and English. He is a regular presenter in various national and international conferences. He will be speaking on implementation strategies to improve blood pressure control. Let's start with primary health care and the smart cuff based volume sphygmography. This is very important. Please proceed, sir. Thank you.
Thank you very much. Good morning, ladies and gentlemen. Today I would like to discuss not a new blood pressure device, but a broader challenge facing hypertension care. Why evidence-based recommendations remain difficult to implement in routine clinical care, and how integrated vascular assessment may help to make guidelines directed more feasible. We have effective antihypertensive drugs, robust clinical evidence, and comprehensive international guidelines. Yet blood pressure control remains inadequate across the most healthcare systems. This discrepancy has become one of the major challenges in cardiovascular prevention. The limitation is no longer the lack of knowledge, but our ability to translate that knowledge into everyday clinical practice. The effectiveness of antihypertensive treatment is well established. Today's challenge is implementation, ensuring that proven recommendations are delivered consistently to patients during routine clinical care. This implementation gap is the focus of today's presentation. Clinical guidelines define what should be done. Implementation science addresses a different question: how can those recommendations become part of everyday clinical workflow? Modern hypertension management extends well beyond blood pressure measurement. Current guidelines emphasize comprehensive cardiovascular assessment, including vascular evaluation, hypertension-mediated organ damage, and overall cardiovascular risk. Accordingly, this first office visit has become much more than confirming elevated blood pressure. It should establish the reference arm, detect vascular asymmetry, assess cardiovascular risk, and identify patients who may benefit from additional vascular evaluation. One simple example is bilateral blood pressure measurement. It requires less than a minute, yet identifies the reference arm, detects clinically relevant interarm difference, and provides additional prognostic information. For this reason, current guidelines recommend measuring blood pressure in both arms during the initial evaluation. None of this recommendation is difficult in isolation. The difficulty arises when they all need to be completed during a routine consultation that also includes history talking, documentation, treatment decision, and patient education. This is precisely where implementation science becomes relevant. Bilateral blood pressure measurement represents only one element of this recommended assessment. This initial evaluation may also include orthostatic blood pressure measurement, identification on the reference arm, assessment for peripheral arterial disease, and in selected patients, evaluation of arterial stiffness. Each recommendation is evidence-based. The challenge lies in incorporating all of them into a single routine visit. These examinations are not inherently complex. However, they are usually performed separately using different device and different workflow. As guideline recommendations continue to expand, the cumulative burden on primary care also increase. This illustrates an important point. Implementation is often constrained not by evidence, but by healthcare resources. Each additional recommendation requires extra time, equipment, staff, or training. Individually, these demands appear modest, but together they create a substantial barrier to routine implementation, particularly in primary care. If fragmented workflows other problem. Simply adding more individual examination is unlikely to improve implementation. A more practical strategy is to integrate several evidence-based assessment into one standardized examination. From an implementation perspective, better workflow may be as important as better evidence. What should an effective implementation strategy achieve? It should be simplify routine practice, standardize the examination, integrate it into routine clinical workflow, and remain scalable for primary health care. These principles provide a useful framework for evaluating practical solutions. Several vascular assessments recommended by contemporary guidelines are traditionally performed as separate examinations. An integrated cuff-based examination combines these assessments within a single standardized workflow. The objective is not to introduce new diagnostic information, but to make exciting guideline recommendations easier to implement in routine clinical practice. The next question is practical. Which technology can support this type of integrated workflow? One possible approach is cuff-based volume sphygmography. Because it is based on the familiar blood pressure cuff, the examination non-invasive, automated, standardized, and requires minimal operator involvement. More importantly, it can support several clinical relevant decisions, from identifying the reference arm and detecting inter-arm differences to screening for peripheral arterial disease, assessing arterial stiffness, refining cardiovascular risk, and identifying patients who may require additional evaluation. Its value therefore lies not in measuring more parameters, but in supporting multiple guideline recommended clinical decisions within one standardized examination. How does it compare with current ESC recommendations? A substantial proportion of the recommended vascular assessment can be incorporated in a single examination, including office blood pressure measurement, inter-arm blood pressure difference, identification of the reference arm, estimation of the ankle brachial index, pulse pressure, and, where appropriate, arterial stiffness. Traditionally, this assessment requires separate procedures. The technology does not change the recommendation. It simply helps implement several of them within the same clinical workflow. American guideline reflects a broader evolution in hypertension management. The emphasis is no longer limited to accurate blood pressure measurement of medication selection. Instead, hypertension is presented as a continuous care pathway beginning with standardized assessment and extending through risk evaluation, treatment, lifestyle support, team-based follow-up, and long-term management. This perspective closely aligns with the concept of implementation in hypertension. Accordingly, technologies should be evaluated not only by what they measure, but also by how effectively they support this entire care pathway. Over the past decade, hypertension guidelines have become increasingly comprehensive. The EAC guidelines define that should be assessed during the initial evaluation, while the American guidelines extend this into a longitudinal model of care. At the same time, the World Health Association calls for turning evidence into action, and Professor Cario has proposed the concept of implementation hypertension to emphasize this systematic application of exciting evidence in everyday practice. Taken together, initiative suggests that the next major advance in hypertension care will depend not on generating more evidence, but on implementing what we already know more effectively. If implementation is now a central challenge, what exactly should be implemented? Professor Cario's framework provides a useful answer. Sorry. It does not introduce new diagnostic or therapeutic recommendations. Instead, it emphasized coordinate implementation of exciting evidence across diagnosis, treatment, patient behavior, healthcare organization, and health policy. This system's perspective reminds us that meaningful improvement cannot rely on a single intervention. Better outcomes require all components of hypertension care to function together. This changes how new technologies should be evaluated. The key question is no longer how many physiological variables a device can measure. Instead, we should ask whether it facilitates the practical delivery of guideline-directed care. An implementation-oriented assessment should be standardized, efficient, reproducible, and capable of generating structured clinical information for longitudinal follow-up. Curve-based vascular assessment represents one example of this approach. A single examination can provide several clinically relevant measurements while fitting into a standardized workflow. This should not be interpreted as evidence of superior clinical outcomes. Rather, it illustrates how diagnostic technology can be aligned with contemporary implementation principles. Conceptual feasibility alone is not sufficient. Any implementation strategy should also be practical within routine clinical care. The example shown how he illustrates one possible outpatient workflow. A single curve-based examination generates automated report that can be incorporated into a physician's assessment without creating additional diagnostic pathways. This example is intended to demonstrate organization feasibility, not clinical superiority. Whether such workflows improve implementation on patient outcomes remain to be established in future multi-center studies. Here is another practical example of workflow organization. This outpatient clinic uses two integrated examination stations that combine curve-based vascular assessment with ECG acquisition. Depending on patient volume, the examinations may be performed by one or two trained nurses using a standardized protocol. Again, the purpose of this example is not to demonstrate effectiveness, but to illustrate that guideline-oriented workflows can be incorporated in routine outpatient practice. Successful implementation depends not only on diagnostic method itself, but also on how clinical processes are organized. All through these documents, we developed independently and for different healthcare systems, they convey remarkably consistent message. The World Health Association emphasized turning evidence into action. The ESC guidelines expand hypertension evaluation to comprehensive cardiovascular assessment. American guidelines present hypertension management as a continuous team-based care pathway. Japanese Society of Hypertension highlights the importance of translating recommendations into everyday clinical practice. Together, these documents indicate that future progress in hypertension care will depend increasingly on implementation rather than on generating entirely new recommendations. To conclude, I would like to leave you with 5 key messages. The first, hypertension is no longer limited by the availability of evidence. The major challenge is implementation. Second, contemporary international guidelines consistently support more comprehensive and longitudinal models of care. Third, successful implementation requires clinical workflow that integrate guideline recommendation without increasing complexity. Fourth, integrated curve-based vascular assessment represents one potential strategy for supporting guideline-directed hypertension care in routine outpatient practice. And finally, the next stage of progress will depend on implementation research that evaluates this approach across different healthcare systems and real-world clinical settings. Thank you very much for your attention.
Thank you very much, sir, for your enlightening lecture. Actually, moreover, you have discussed more technical details. Actually, this thing is the implemented strategy to improve the blood sugar since for a long time it's coming, but you have incorporated the modern things and all. Nowadays, the home BP monitoring and ambulant BP monitoring, everything is okay. Now, I just appreciate you because you have gone deep into the technical aspects. So this is an excellent presentation. Thank you very much, sir.
Thank you.